Janet, can you nod or something if it looks like it's supposed to look, please? Perfect. Thank you. Look at that first try. All right. So the announcements. This is the goal for next week. The impact of alcohol on athletic performance and recovery and what that does, especially if you're training for something, just alcohol's effects. Then you can kind of see what's coming up. Still working on filling some spots in February. There is the one that we are not having in April because it is back-to-back presenting in Atlanta. So we are going to not do that. Still free CME, of course. Please turn your videos on if you don't mind. The CME thing will come in an email after this. Otherwise, you will see it pop up in the chat. Kurt is presenting and he gets really anxious when he looks at boxes. So
yeah,
yeah,
need some people.
Let us know if there's more than one person in your room, of course. And if you have questions throughout, please chat them in. I will just interrupt Kurt.
Yes.
I think that's appropriate. You know how to answer on the fly. We're always here for you, of course. Any questions, any protocols, anything you might need or want, or basically anything. That's how you can reach us. Erin's on as well. That's her email. Don't hesitate.
Oh, lots of videos. This is great.
This is amazing. The online site of how you can register for Echo, see if there's other Echoes out there, be able to see taped versions. Manual is still in process. And the Addiction Connection podcast yesterday shared decision making, which seems kind of like a bizarre topic to podcast on, but it actually ended up being a really super fun podcast to tape. Just kind of how you have these conversations with patients and how you can, especially if we're talking about tapering opioids, so chronic non-cancer pain, opioid prescriptions, how to get that to happen in a way that the patient feels empowered as well and out of the paternalistic doctoring form. And any questions are that, there's that email. Okay, so I will introduce Kurt.
Yeah, the speaker.
The speaker today.
Just give me that. All right, so this is, we actually did Kratom a while back, and it's interesting because there's not a lot of stuff on Kratom, but there just keeps getting more and more things that are being looked at. But as you'll find out, there's still a lot of things about Kratom we don't know. But a fair amount of newer things that I came across in kind of researching this. So we'll do a little bit of a review. We'll talk about some of the other things that have kind of shown to be a problem with Kratom. And we see a lot of Kratom. I don't know what you've been seeing lately, but I probably had 2 new Kratom patients in the last 3 or 4 weeks.
I think we've been hearing about it more in the state lately too. And I wonder, is that, and maybe you're going to say this, but if what your patients have said, if it's because they're afraid of fentanyl.
No, actually,
really?
Most of the patients were taking it did not realize that it was a problem. So
no, well, okay. So they weren't choosing that as opposed to accidental fentanyl. Yeah.
All right. So went down that internet rabbit hole. And once you start Googling Kratom, you can basically spend your whole night and into the early mornings finding things.
Only if you have no children.
That's correct. I have no kids and nothing to get up for, nothing to live for, really. So I'm just on that internet all the time. So we'll review kind of the chemical makeup of Kratom. We're going to talk a little bit about some of the clinical effects. So how is Kratom really related to some of the overdose deaths, which is pretty interesting, and some of the common treatments and how we treat it in our clinic. But again, this is not something that is really well worked out yet. Some of the toxicological, is that a word? Mm-hmm. Concerns, and then a little bit about the mental health effects of it. So just some new things that have kind of come out. Remember, this is actually a tree. It's related to the coffee plant, which I think is...
What is going on? You're trying to butt dial somebody.
Yeah, I'm trying. Yeah, sorry about that. All right. So anyway, the evergreen tree, remember that it's related to the coffee plant, and it has markedly different problems associated with than caffeine. It's mostly in Southeast Asia, but these plants have now been moved to many different countries, which I'll explain how that affects what's in Kratom. And again, historically, this was something that was used in Malaysia and parts of that world for a long time, recreationally, and also just people use it on a normal day, chew on those leaves when they're at work. So it's in a leaf chewing episode is not quite as impactful as what you're buying at the store when you stop at the convenience store between Brainerd and Little Falls and buy it when you see their big red Kratom sign. So to understand that it has both stimulant and opioid properties. So I think that's really important to understand. These are indole alkaloids, right? We got two things that are the main alkaloids, and that's mitragynine and then 7-hydroxymitragynine. And so they're only slightly different, but these are partial agonists on the opioid receptor. So understand that, unfortunately, there's also a lot other things in kratom. In a way, this is almost like a marijuana talk, because there's 100 things in marijuana, very few of them have been studied. And there's two main alkaloids we know that give you the clinical effect, but there's another 50 hanging around. So the effects of those things are largely unknown. And we don't really know what the metabolites of those things are as well. So if we mix this up and we take low doses, and again, how do you define a low dose? And how do you define a high dose?
A leaf would be a low dose.
A leaf would be definitely a low dose. But I think the thing to understand about kratom that we'll talk about in a minute is that it can be so different what you're getting in the bottle based on where it comes from. And so what you might think is a low dose may or may not be, because there's no standardization. So where is it from? There are some studies where they have taken different samples that have come from different countries, only to show that the amount of mitragynine and 7-hydroxymitragynine can be vastly different, up to 2 or 3 times different. And a lot of it depends on kind of the environmental and soil factors. And there's 3 types of trees. And so depending on which tree it is, where it was grown, how they produced it once they harvest these leaves, it can make an enormous difference in what you buy. And in fact, some of the things, if you go online, they will talk about kratom that's fortified. They have one that's
That sounds safe.
Yeah, it sounds safe. We've got fortified kratom, and there's one, although politically incorrect, it says it's called pimped up, and it's one that's supposed to be much stronger. I forget exactly what the rest of the name was, but it's pimped up kratom is what they sell it as. So lots of different types of ways it shows up, and lots of different countries it comes from, and again, basically unregulated. So these are very distinct from opioids, and I think that's one of the main things you need to take away from the talk, is that they're a very distinctly different thing, and although they have some overlapping kind of things that they will do similar to opioids, they are referred to as atypical opioids. And so you're going to find that some of the things that we see with it are really pretty interesting.
I have a random question.
Yes, random question.
Would you consider it an atypical opiate because it's naturally?
It would probably be an opiate because it's natural. And I could see Charlie kind of turn his head there, but
that's a smart question, huh, Charlie? That's like a Charlie question.
Yeah, I was waiting for maybe Charlie to come up with that one. So mitragynine, which is the main thing, and again, mitragynine actually, its metabolite is 7-hydroxymitragynine. It's not associated really with the constipation. It's not associated with the respiratory depression, or maybe even some of the dependence that you get from kratom. And I think it's important to point out the respiratory depression, because we're going to talk about that again. You can take an enormous amount of this and you will not get respiratory depression. You might die from some other problem with it or some drug interaction, but you won't die of respiratory depression. We'll talk about that a little bit in a minute when we talk about some of the different studies on overdose deaths and what's in people's blood. So it's really important to understand that the 7-hydroxymitragynine has really never been studied except in animal models, right? But it's only 2% of the total alkaloids that you can get out of the leaves. And so these two things are a small portion of the alkaloids that are in kratom. And it's really pretty interesting that if you look at mitragynine, now on the left is me in a white shirt. That's when I was in high school. I looked vastly different then. Yeah, and as you can see, that would be 7-hydroxymitragynine, because that's 46 times more potent than mitragynine and 13 times more potent than morphine on the mu receptor. So we're talking about something that's really pretty potent.
How long did it take you to come up with this type of an image for this slide?
I just took it from my high school yearbook. And so if we move on, which
next
we're going
week,
to,
if I do this talk because it's on exercise and such, I'm pulling in pictures from your high school yearbook because I got them. So stay tuned, everybody. We will see Curtin High School next week.
No, we won't.
Yes, we will.
So historically, how is this used? And I think I've seen most of these in the clinic. Typically, it's used in liquid form. In fact, a lot of people will buy it as a powder. I had a guy who was a welder, and he would put this in his water bottle, and he would take drinks out of his water bottle all day
And all night.
and all night. And he was previously had been a guy who'd been using heroin, and he had switched to Kratom. And he was using that for a number of years before I saw him. Sometimes, and we see the capsules, which are relatively expensive. If you look at these in some of the stores, you'll get 25 of these, and it'll sometimes cost you $25 to $40 for these capsules. So people, it's not unusual to see people spending $40 to $50 a day on their Kratom. A lot of people make tea, and you can go online and you can buy it so that you can brew tea, and then they use sweeteners to kind of take away the bitterness of it. There actually are case reports of IV use, and these are people who get really sick. There's been some really bad cases where people have tried to use it IV and had some significant hospitalizations associated with that. There is some inhalation of this where people have taken the leaves or the stuff that they buy at the store and put it in something to try and smoke it. That is also not a good thing.
But it's not recommended because the rest of it is recommended.
Not recommended by the association, the Kratom Association.
Oh, okay.
No, they don't recommend that.
It's just weird verbiage on this slide.
Yeah.
You know?
So who uses it? Well, if you look at this is largely a white disease. 90% of the people who use Kratom are actually white and often female in that 40-year-old group. Although we have seen some females, I would have to say in my practice, I probably see more males.
My first Kratom patient was a female, mid to late 30s.
Yeah, so we do see that. And about 59% of the people who use Kratom actually use it every single day. So it is a commonly used thing as far as a daily supplement, if you will. And again, the question is that person going to escalate their use? It's metabolized in the liver, which we'll talk about shortly, how sometimes, especially with things like acetaminophen or other drugs that may affect your liver, it can kind of be an issue the way it's metabolized. I'm not kidding you. If you look at different studies and different things, because it's not been studied well, this whole half-life of Kratom is all over the board. And if you look at some of the different things where they've checked it on people drinking tea, it can be as really as short as 6 or 7 hour half-life to as long as 28, 29 hours. And so it can really be variable. There were some studies that showed that the half-life, if you take it orally, might be a lot closer to 2 or 3 hours. But again, it's all over the board. And again, it depends on what you're getting and exactly how strong it is. And again, the active metabolite's at 7-hydroxymetragenine. So that's the one that appears to be causing most of the effects of it. So how about the pharmacokinetics? Well, this is absorbed, and the distribution of it is really poorly understood. Okay. Most of the studies have actually been done in rats, which sometimes kind of can be correlated with how it might act in humans, but it's really not something that's well known. Again, one of those things that we may not know for a long time. What we do know is that the peak plasma concentrations typically are around an hour, and that's in tea drinkers, which obviously the absorption of that is probably much different than if you take a capsule or something similar to that. And it has a very high volume of distribution. They believe that it actually leaves the circulatory system, but it's very much protein bound. And so there's this whole thought that we don't get it in our brain quite as well as we would with certain other opioids. But in some way, it's lipophilic as well. And so again, nobody really has any clue where this ends up in your body. It's about 3% bioavailable, and that's really not a lot. I think if you absorbed more of it, it would probably be a bigger problem than it is already. But it's not really water soluble. So
that means, is it grainy when they drink it?
I think it is.
You know, that fiber, if you have fiber stuff too.
It's kind of fibrous, yeah. So here's the interesting part about Kratom, and I think that this is probably different than I thought before. I mean, as more information has come out, it's become very obvious that on its standing by itself, Kratom is typically not going to cause that respiratory depression and death. Okay. And so when we talk about some of the studies on overdoses here in a minute, we're not going to find a ton of times where kratom has killed someone on its own. And it's interesting that its median effective dose is 20 times less than the lethal dose. So really, you got a pretty wide area there where you can use in and typically not cause yourself a problem. Now, that's really if you aren't taking something else. And if we look at some of the death studies, we're going to find that it's typically more the interactions or potentially the combined actions of other opioids with a partial opioid that is more often related to the death of somebody that has been taking this. So why do people take it? Well, what people want it to do is they want it to increase their energy, and that's often how it's sold. I've seen ads where it's been sold because it improves your memory, although that's never been proven. And actually, the opposite has been proven. It much like alcohol or something else, it's been kind of touted as improving your sociability, that you're like more friendly when you're on kratom and you're chatty and talkative with people. And a lot of times, again, at the very low doses, if you look at the way it's just naturally used in Malaysia, it's like we use caffeine during the day to keep us awake at our job. They use it in that fashion in Malaysia, and it's considered very common. Although one interesting, I'll go off in the weeds for a second. One of the interesting things in Malaysia is for a man to use kratom is considered okay, because they have to support their family and they have to, be the breadwinner. If you're a woman and you're using it in Malaysia, that is not something you talk about, because you're looked down upon as a woman using this particular supplement. And again, at higher doses, it seems to, and again, not great studies, it seems to improve pain.
Oh, when my sister was in Malaysia for a year, she said it was, people be walking to work to go work in the fields, the men, and they would literally take leaves off the trees as they walked to work and chew on them because it was hot, it was grueling work, and it would help kind of ease some of the vigorous work they have.
Yeah, Charlie, that's interesting. Gin and tonic's a bad thing in India. We don't know why. All right.
The gin and tonic.
So how about the dose? Let's talk about the dose. And it's funny because the last person I saw is the first person that has ever told me how much he was taking. Most people get these big tubs of kratom and they're dumping it into like their water bottle, or they're just taking it and pouring it like you would Miralax in a cup and then drinking it. Okay.
My first patient knew how many capsules she was
Yes,
taking.
and this guy came in and said, I'm taking 60 milligrams a day. And so that's how he was doing it by the pills. But again, it's not standardized. So, we really don't know how much he's taking. If you take more than 5 milligrams, it appears to have a bit of a depressant effect and an antidepressant effect. That's a misspell there, and an opioid effect. But really low dose, again, the way they're using it in Malaysia when they're heading out to the fields, it's a bit stimulating. It's your coffee. Although some people use methamphetamine like their coffee, and we see that as well.
Or Diet Mountain Dew.
Or Diet Mountain Dew. So these are effects when it's used intermittently. Okay, so if people are not using it every single day, these are the effects that you're going to see. But how about if we are mixing this with lots of other stuff? And I think that's what poison control sees. And actually, there was a study done. This is actually a study done from 2011 to 2017, and they actually looked at people who were only taking kratom, 1,100 people of the exposures. Okay, and over 1,000 of these people were having some pretty significant adverse clinical effects from kratom alone.
Hold on.
Oops, sorry.
There.
And this is the most common things that we see. And again, the one thing I want to point out is the confusion side of this, and I'll explain that in a slide that's down the road. But I want you to keep the confusion and vomiting in mind. Also, tachycardia, drowsiness, and withdrawal. Now, most of us that have seen kratom patients have seen them when they're in withdrawal, and it can be pretty long, drawn-out thing, which is a little bit different than what you'll find in the literature. My experience with kratom withdrawal is that it's been really hard to control, that patients typically have taken a fair amount of you have to give them a lot of Suboxone to kind of get them out of it. And I saw this guy, my last patient, a week out, and he was still pretty sick. But that doesn't really correlate with what some people say about it as far as withdrawal
Well, and
goes.
I usually have seen it, it's pretty quick, like it happens
Yes.
pretty quickly after that last use. They can time it pretty well.
And it's interesting because if you look at how it's reported when they do, for instance, online surveys, most people say that that the withdrawal is relatively mild, but clearly there's the ones that come see us are selected out and they're really sick. And it may be that they're taking more, it may be that they're taking a different type, one that's higher in mitragynine. The serious clinical effects are, well, they're serious. Does that sound right? They can have
You went
seizures.
to medical school.
Yeah, they can have respiratory depression, coma. The interesting thing, of course, is the bilirubin issues with the liver, and that often can be mixed with some other, if they're also drinking alcohol, it can be a real issue. But really renal failure, respiratory arrest, and cardiac arrest. And again, often this is medication related, and we'll talk about that. If you look at the ones that came into poison control, more than half of that group ended up in the hospital getting IV fluids, getting benzos, some of them getting naloxone, intubation. At times they can be really pretty sick, especially in a person. Often when they looked at the cases that went poorly, they were people that had taken large amounts very quickly who are opioid naive. And that's one thing to think about, is that often these patients, there's two ways that we see these patients sometimes. Sometimes they have been on opioids previously and switched over to Kratom, and I've seen a couple of those, but often they've started this on their own thinking it's just something they should be taking for chronic pain, and they may escalate very quickly how much they take. Because remember, to get to the pain improvement part of this drug, you gotta go above that 5 milligrams. And I have seen people thinking they're taking 60 to 100, so roughly. So one of the interesting things is that there's not a lot of acute side effects. You can get constipation, and if you have some liver issue, which again might be related to another substance, probably alcohol or a lot of acetaminophen intake, the liver toxicity can be a very acute or very non-acute problem that over time people suddenly turn yellow and come into the hospital not knowing what's going on. In many countries, it's actually used for diarrhea, and in Malaysia, that's a very common thing to take when you have diarrhea. And here we are, we're to the withdrawal. And again, I find this very interesting because if you read all of the different kind of these surveys that have been done online about patients using Kratom, it can be very different from patient to patient. And I think we see that with opioids as well. Some people can go through withdrawals on fentanyl and amazingly not be that sick. And other people are really, they end up in the ER. But it's funny, the things that I found talked a little bit about, with long-term use, it would start in 12 to 24 hours. And my experience is it's much, much shorter than that. I've had many patients say, I started using Kratom 2 years ago, and now I'm taking it every 2 to 3 hours. I'm getting up at night to take it, because if I don't get up at night, when I wake up, I'm so sick, I can hardly drink it. So they will wake up at night, take a drink out of their water bottle that has Kratom in it, and then they'll relax and go back to sleep. In some of these different surveys, people talked about it lasting 3 to 7 days. And very obviously in the neonatal units, they have seen a withdrawal in infants that they have associated with Kratom. So it is very similar to opioids. These patients will really look pretty sick and miserable. It's interesting because the hardest part, and there was a lot of online things about people telling their stories of how they tried to just stop on their own. They tried to taper, and that they had such horrible cravings for it that they would end up going back. And of course, CDC has some data on it, on both unintentional and undetermined, kind of the opioid overdose deaths. They actually looked at these, and they actually went through 11 different states back about 5-6 years ago, and then took data from another 27 states from July to December in 2017. And they compiled a list of almost 28,000 people who had died from overdose to try and kind of look through exactly what they had in their system. And part of this was not, it wasn't looking for kratom. This was just looking for anything. And as we all know, metragenine is a pretty tough thing to get a test on. We send those, we send those out and it takes forever to get them back. They're not useful really because it takes too long to get them. So they ended up having 152 cases out of all of those. So that's, again, 28,000. There was only 152 that had kratom in it post-mortem. And it was only identified as the cause of death in less than 100 people. So let's just say it's 100 out of 28,000 people actually died from kratom, with kratom in their system. And only 7 of them was it the only substance detected. So it is pretty rare taking kratom by itself that typically you're going to overdose and die. It's more likely you're going to have another issue. And if you look at the 84 cases of other co-occurring substances, again, you had all of these other things classically in there. So it was a mixture of kratom with lots of other things that typically we see. And in fact, there's a lot of really good data that people that use kratom typically use many other substances. The average person that's using kratom is also dabbling in many other different substances in general. So it's not surprising that you would see these things in those patients that overdosed. So there is the American Kratom Association, and they are doing everything they can to make sure that this stays legal. There are states that it is not legal in, which I'll show you in a moment, one of them being right to our east. It is not legal in Canada. You cannot buy it. Yeah, to our east.
Canada.
No, Wisconsin.
You said Canada.
Oh, I'm sorry. Canada? No, to our east. It's that state that I try and forget, and I clearly did. Wisconsin. And it's interesting because my patient told me how he went to Wisconsin on a vacation for a week, ran out of kratom and could not find any. And then found out it was illegal. So it is interesting that some of the states, and there's some out on the East Coast that are also, it's illegal, I believe Maine, and some of those we'll show you in a second. Here's the big problem. The big problem is that if you're taking kratom, there are lots of things that will interact with it and have caused death. Probably the number one of all of these is actually Seroquel. The last patient I had that was taking, it kind of made me panic. I didn't notice it right away. He was taking kratom, and when he left, I happened to look at his list, and here he had Seroquel on his list. And Seroquel is one that's been really linked to a lot of deaths mixed with kratom. And no, again, not a lot of studies done on this, but Seroquel is probably at the top of this list as far as acute problems. But really not such unusual drugs. Amlodipine used relatively commonly for blood pressure, some SSRIs, and again, acetaminophen and alcohol, because of that whole liver metabolism, is really important for you to kind of keep in mind. So what do we do with an overdose? Well, if somebody comes in and they're clearly kind of confused and out of it, and you have any absolute clue that it's kratom, we frankly would treat this much like we would treat any opioid overdose. You'd give them naloxone. And that's what we do. We actually see these patients, of course, non-acutely, and we're putting them on Suboxone. But for the most part, it's that whole liver issue too that you have to keep in mind as far as acute hepatitis and whether or not you need to treat that. And so very important that you get a full set of labs so that you have an idea if this is a person that's been using it long term, whether they've caused themselves any other problems. Again, just like any other opioid, we can use the other types of medicines that we often use, like clonidine and Zofran. I don't know whether you can go to a methadone clinic and get put on. Maybe Charlie, I don't know if he's still there.
No, he had to go do a consult.
Oh.
Texas.
Yeah, I'd love to know whether he'd ever in the methadone clinic put somebody on methadone because of that. But it is effective. We know that. So dependence potential, and this is the thing online with even some of the online surveys. There are no good studies. There are surveys that people seem not to develop dependence or overdose. And I think that, again, the overdose side of this, I think that's pretty clear, crystal clear. They don't really overdose frequently on Kratom because of the respiratory depression issue. They just don't get that. But I think dependence is clearly a problem, at least that we see with some frequency. But like I said earlier, often people that end up on Kratom are people that have had a prior use disorder, and again, are often using other substances with Kratom. And I would say more often than not. So it's not known. Nobody knows how many people are using it. There are some guesses that there are 3 to 4 million people using Kratom on a daily basis, just based on sales, but nobody really has an idea how many people are actually dependent and buying it on a daily basis. Again, a lot of this is done online, especially in bulk. So, you know, most of the surveys, people feel that their dependent symptoms are mild than when they were on other full agonist opioids. Again, the same treatments can be used. So there's some other risks. And again, that lack of regulatory oversight is really what makes this a bit of a dangerous game. It's like, you know, how pure is it? You know, what else might be in it? How potent is it? You know, how safe is this with the medications that I take? And it's interesting because, for instance, one of the people that I saw was on Kratom, I had seen him previously for a different problem, for I think it was alcohol. And he came back because he was taking Kratom at the time I saw him, but he didn't realize it was something he should talk to me about. And then he happened to run across something about Kratom and being addictive. And he came back and started asking questions. So people, I think the biggest part of it is not regulated. People don't really realize that it's going to take them, you know, take them down and give them some issues. And really,
it's natural.
It's natural. I think one of the big things to understand is that there are many cases of Kratom being adulterated. You know, that during this process of making the Kratom and bottling it, some of this is done in foreign countries where there's not a lot of oversight. And so often they will have things in them that you're not expected. And one of the things that happens is the 7-hydroxymetragenine, which is the one that gives most of the kick to the Kratom, is often artificially increased. And so you'll end up with a Kratom that is fortified or, you know, or something similar to that. Often they add synthetic substances, you know, different desmethyltramadol, which, you know, these particular types of things, these turbo, I think one of these was called turbo Kratom. They put these other stimulants in them or tramadol in them, and they have been actually linked to overdose deaths. Interestingly, there's also been salmonella outbreaks related to Kratom. And I think one of the things we are going to talk about next is the heavy metal contamination, which I had never heard of until just this last month when I started kind of looking into this. There's a lot of new work being done where they've been testing Kratom and looking at the heavy metal contamination that exists in Kratom. So let's talk about the contaminants. So lead. One of the things that public health implications, possible sources of lead. The FDA actually took 30 different Kratom products. And initially they were looking for a bunch of different heavy metals, and they went for nickel and lead. And they found that not only does it have a fair amount of nickel in it almost routinely, but almost all of them had high levels of lead. All but 2 had high levels of lead. And the question is, well, how much lead? This guy, and I'm not even going to say his name, Prozelek. He went around Chicago head shops and actually bought 8 Kratom products. And they basically ran these through their lab and found a lot of lead, nickel, iron, and even cadmium. That's spelled incorrectly. And researchers felt that really the lead was the biggest hazard to the Kratom user. And we talked about that earlier with some of the side effects of lead. And one of the things that they were concerned about is when they were seeing patients who were on these very large doses of Kratom, one would have to ask themselves, are some of these symptoms that people get while they're on Kratom related to the lead? Because of some of the things that lead can cause. And especially when you look at some of these patients that have shown up with renal issues, Some of them shown up with, psychological issues or behavioral issues. They were confusion and other related things. And so there is some suggestion that when we see somebody using high amounts of kratom, that we should be considering checking their lead levels to see how high it is, because there is great variation in all of the different samples that you can buy coming from different countries.
So is that kind of that soil-based thing?
So, that's
Are they
exactly
thinking
it.
that's what it's coming from versus like it getting stepped on?
Yeah, it's that, and it's also, and I don't know if I put this in here, they found that the different trees, the different soil, the different country could sometimes predict how much lead was going to be in it. But from bottle to bottle, it was very different. So,
Interesting.
so again, I frankly wish I've had one guy who was taking probably a couple 100 milligrams of this a day, based on what he was buying. And probably at the time, I probably should have checked the lead level just to see where he was at. But if we look at 50 grams as kind of the line where they think that above that, potentially you could have lead toxicity based on your kratom intake. And so I think it's something for all of us to consider. There's probably nobody on this call that if you're seeing patients, you maybe haven't bumped into somebody on kratom. It's certainly something that we have to ask about. There is a fair amount of concern when they did this study, when they started looking into it, that they probably had missed people getting GI distress from their kratom, which is unusual because normally you'd get constipation, that potentially it was related to the lead levels. But it's, it's really something interesting that's gone on here lately as well, is kratom, when people take kratom, is it harm reduction? So we're going to shift gears here. And this is, I found very fascinating, and I'll tell you why. I think from my standpoint, if we look at alcohol, for instance, how many people die from complications of alcohol every year? It's like 100,000 people, right? It's a lot of people. And I always had this extremely negative feeling about kratom. And in fact, kratom doesn't kill a lot of people. It causes a lot of morbidity, and it can potentially cause some significant medical complications. But the reality is that if people are taking kratom as opposed to fentanyl, probably you could look at this as harm reduction. I don't like to admit that, but it's like, yeah, it's probably harm reduction, because almost 20% of users actually on surveys, and again, these aren't studies, these are on surveys, felt they were taking kratom to replace opioids. And if we look at it, your chance of overdosing is much less common if you're taking kratom and not fentanyl. So it probably is a form of harm reduction that makes me uncomfortable, but it probably is.
Okay, speaking of that, so I asked Charlie, he responded. He said they haven't done it much, so the methadone for kratom.
Okay.
But they could do it if the use disorder were severe enough. And he said he would look at it more carefully because it's kind of a little bit harder to say, yes, for sure, there is an opiate or opioid dependence and use disorder there. So it's a little bit harder to diagnose it, to treat it in a methadone clinic.
Yeah.
And I had questioned, is it, compared to like a fentanyl person, and, a lot of methadone clinics have limited numbers of patients they can have. And so would a fentanyl patient benefit more from a methadone clinic than a kratom patient?
Yeah.
So anyway.
Interesting. And so again, kratom deaths don't occur that often except from drug interactions. So, I'll back up a second, but let me just say this, so for me, I think if we find somebody that's on kratom, let's say they tell you that they're taking kratom, I think it's important to tell them the risks of kratom. They may not see a risk. Do you tell them are they going to stop based on the information that you give them? And if they say, I used to be using fentanyl, well, we probably are in a slightly better place, but it's only, in my experience, it's a matter of time until people escalate, and then they are using so much and having so many side effects that they end up kind of coming in. So I think for me, it's going to be a whole different conversation than I probably have had with people in the past who said, yeah, I'm taking kratom. I think I'm going to be a little bit more moderate in my recommendations and make suggestions. I don't know.
But I wonder, like, as far as like workplace and, life and whatever, that's not on a random urine drug screen. And, even in states where cannabis is legal, they still can't get certain jobs, even though it's legal in that state. And so would this be something at some point people would look at to see, like, what does this do to someone's ability to function in their life, like their functional abilities to have jobs and such?
Yeah, and it's a tough call. So this is where it's legal and where it's not. Again, Wisconsin, illegal, Indiana, Arkansas, Alabama, and Vermont. The Kratom Association, of course, is trying to get this. What's that?
I want to just point
Oh,
out Delaware
go
is
ahead.
not written on there, which is weird to me because Rhode Island is. But
Oh,
my question though on this slide for real is, how did these states come to make it illegal versus other states? Like,
no idea.
where did that come from and when? Just, it's curious if there's not a lot of studies. How did that happen?
No idea. Yeah. So yeah, and so this is American Kratom Association. Now, the American Kratom Association, their whole goal is to make sure that this does not go illegal everywhere. And they don't like the FDA. I'll point that out right away. They think the FDA has drugged their feet, not making this legal. Their fact sheet, I would say, is not real factual. They claim that 0 deaths have been proven to be caused by kratom, but there are, I guess it depends on what your definition of proven. And they, interestingly, on their website, it says no more potential for substance use disorder than caffeine. I drink caffeine. I've never had to take Suboxone to get off it, although close. But
Diet Dr. Pepper.
Yeah, Diet Dr. Pepper is kind of the Suboxone of caffeine. But and they had of course, an online survey where 0% of emergency healthcare professionals and EMTs that responded to an online survey supported a ban. That all 4 of those people.
I
So
wonder if they even knew what it was.
yeah, and that's the thing. I mean, I talk to primary care people all the time, and they have never heard of kratom. And so I find it hard to imagine that an EMT would have heard of kratom. We just don't see it
We
because
didn't know what it was when we had that first patient either.
yeah. And this is actually the exposures by the poison control. If you can see what's happened really in the last 7 or 8 years is the number of phone calls that they're getting are going up substantially. And so we know that the use of it is really accelerating. This is actually how long the American Kratom Association has been waiting for a meeting to talk to the FDA. They post this on their website. It changes every second, of course, to say how long it's been since the FDA has been avoiding them. But I think there's a lot of considerations that we have to have about this. And I think that one of the biggest problems I see with it is really that there's no studies. It's in a way, it's like marijuana that way as well. There's no studies that tell us, where's the therapeutic range, what's the dose, and are people's metabolisms different? Is there anybody else that's significantly at risk using it with other health problems? And so I just think there's so much that needs to be known. I think for us, it's knowing that when a patient comes in, they've been taking it and they're in withdrawal, that we need to treat them like we would an opioid person. So the summary, of course, it's it's both a stimulant and has opioid properties. It's a drug, but it's an herb, and it's got a lot of interactions, some of which can be fatal. That'd be a fable. It can be fatal, and again, it keeps Seroquel and acetaminophen in your brain. That's not something you want people mixing it with. It's not a common thing to overdose by itself, but again, it's a lot of polydrug use in patients that typically take kratom. And lastly, treatment of it is not well studied, but we've been using buprenorphine on this for probably 5 or 6 years, and really didn't know a different way to help these people. So lots of references. Feel free to find those. Very interesting topic. If there's any questions, obviously I'd entertain them if anybody has any thoughts.
Well, and I don't know how much we talked about this, but what I've noticed from my kratom patients is that they're on higher doses of Suboxone than even heroin back in the day. I wouldn't necessarily more than fentanyl, but greater than the good old days of heroin. But an induction on this seems to be one that you can go up, like the induction of the old days, where you can go up quickly, as opposed to more like fentanyl waiting for the precipitated. So
it's interesting because when I had a conversation with Brian Grant, and they had a kratom patient that actually precipitated that they
Interesting.
were not sick enough. And so it's not that they can't precipitate. So I think people need to understand that. They can, but just make sure that when you start the Suboxone, that they're actually in withdrawal, that they have good withdrawal. And I can't remember how much he said they gave the person, but they got horribly ill. So kind of an interesting case. I wish he's not available on Wednesdays. I would have loved to have him talk about that case.
I love Aaron's question. It's not necessarily related to Kratom per se, but if they've tested like the cannabis products for things like lead and heavy metal poisoning, I mean, that'd be interesting to look into.
Yeah, not to my knowledge. So there was no case thing that we had, but we certainly have many patients who've been taking this. So I think if anybody has any questions or, it'd be interesting to see if anybody wanted to just tell their experience with Kratom, if they've seen much of it. I don't know, Dave, have you seen many? Oh, you're muted.
I've got one. Hang on.
Little echo.
Little echo to go with the big echo.
There you go.
I've got one guy on it.
I can hear myself laugh. Isn't that fun?
No, one of you is enough.
I've got one guy on it, and interestingly, he was mostly shoplifting it,
Interesting.
and he had gotten caught a couple times and pleaded with the shop owner and said, "I'll never come back in here." And he was able to keep doing it, but he's doing well on it.
Yeah.
And I think he had, if I remember right, I think he has ADD too. So I kind of wonder about the stimulant effect of it.
Yeah, interesting.
Did he tell you how he ended up on it? Like, was it just, here, I'm going to try Kratom, or had he come from something else, or what was the progression, if you're aware?
Come back to me. I'll let you know in just a second. I can look it up.
Carissa, I don't know if you wanted to comment at all. Otherwise it's in the chat, and thank you for sharing that about your brother. And I don't know if there's anything you'd want to add to that at all.
Where is she?
She's in the bottom, but she might not want to either.
Okay,
Bye.
yeah. So it's interesting. And Aaron, are the Kratom pure? Or are they totally unpredictable like THC? Yeah, they're unpredictable. There's just different things in everyone, and they're all produced differently. And one of the things they talked about was how even just the process of drying the Kratom was different in every plant, every person that's putting this out there. So how they are drying it, how much water is in it, what's in the soil makes a huge difference. So
That's interesting.
yeah, Christine says, I have one patient who left my clinic to use Kratom as a way to get off Suboxone. He came back and remained stable. Yeah. I think that's something that we've seen where people, and there are people that are, and Aaron and I have had discussions about this because we had somebody emailing that was saying they wanted to use Kratom to help people get off fentanyl and then switch them to Suboxone. I guess I wouldn't recommend that. I don't know about you. To me, it's like, I'd rather use something that is FDA approved in this situation, which is Suboxone.
I mean, but you could look at it as it's less likely to precipitate a Kratom. And you could have, I mean, they switch themselves from fentanyl to Kratom, and then you just do the induction from the Kratom. Maybe it's easier.
Yeah.
You can get them to higher. I'm not saying that's what I would recommend, but
I'm going the same way I've been going. So, all right. Anything else before we go? Dave, you're still looking, huh?
Yeah, interestingly, I had seen this guy for a couple of years before he admitted it. He was not on prior opioids. And what happened was his wife found the Kratom. And he had planned on trying to get off of it. And that's what pushed him sooner. So he's been on it for a couple of years now and doing really well.
Yeah. And my first patient, she was actually not seeing me as an OB patient, but was seeing the OB and had said something like she had this, non-specific kind of back pain, and actually on her own mentioned it to the provider saying, I've been on this stuff and I'm really trying to get off of it because I'm pregnant and don't want that, I'm trying to get off everything because my baby. And was having a hard time getting off of it, and, found out what it was, and they came to talk to us. We're like, oh, okay, well, we'll see you. And she was on 24 of Suboxone for quite a while, and
Yeah,
eventually was able to taper to 16, but then remained on that.
yeah. And it's interesting, I have one pregnant lady now who is taking Kratom, and we switched her over at about 4 weeks when she showed up. So clearly you don't want to precipitate that person. So you want to make sure that they're a little sick when you switch them over. But I think Kratom's been associated with more pregnancy issues, very obviously, than Suboxone. So, all right, fun topic. We'll wait a year and we'll see what else comes out, and I'll be back.
Right.
So-
Yeah. Does it get legalized?
Yeah.
Or made illegal? It's
All right.
interesting.
Well, thanks everybody for coming. Next week, exercise and what?
Alcohol.
And alcohol. Should be fun. So
Heather and Chris, this is Kendra. Hey, I'm got a quick question. If you saw the change in the FDA with getting rid of the X waiver.
yeah, that's pretty much a done deal.
It's good and scary at the same time in our world, I think, and because it obviously increases availability for patients and access for patients. One, you have to have providers that are wanting to do it. I'm interested to see how many providers start wanting to do it that didn't already. Was this really a huge barrier for providers, or was it not? I think, that'll be interesting to see. The fear is that they're doing the right thing. If they want to do it, great. I mean, that's awesome that they're willing to do it. It's just making sure people are aware of
How to
ins
do
and
it.
outs. It'd be different again in heroin days, where doing an induction was pretty darn straightforward. It's a lot more complicated now.
Yeah.
So really having the ability to support providers out there that are wanting to do it and afraid of it, maybe because they don't know exactly, but
Yeah. So time will tell whether it's a good thing or bad thing.
and I think it's interesting because more patients that I've seen have taken Suboxone and are afraid of precipitated now because of the fentanyl. Patients will come in, I'm afraid to do that again. And so it'd be interesting to see a provider who's never done it and then hears that, and how does that work too? So
We'll get more frantic calls. Oh my God, here's what happened. Okay, so, all right, well, time will tell.